Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thanks everyone for having me. We had divided up our CROI update, and so I'll be talking about what I'm calling co-occurring conditions or comorbidities. I have no disclosures. I divided this into 3 sections. Obviously, there are a lot of co-occurring conditions, but I wanted to focus on updates on anal cancer screening strategies, review some updates in metabolic complications of HIV, and really specifically with the use of semaglutide, and then finally some updates in Hep B vaccination, and we'll be reminded of the Beehive study. So starting off with anal dysplasia screening. So we know that the incidence of anal cancer is high among people with HIV, particularly among men who have sex with men. We've all talked about now a few times the ANCHOR trial, which demonstrated that treating anal HSIL, or high-grade squamous intraepithelial lesions, reduces the incidence of anal cancer quite significantly, so a 57% reduction. The trouble is, high-resolution anoscopy is the gold standard for HSIL detection, but availability remains quite limited. And so what we really need is practical strategies to approach anal cancer screening in people with HIV, and that might include prioritization of referrals by demographics like age and MSM, low CD4 nadir, and then cytology and high-risk HPV strains. And so there were a few studies that talked about some of these strategies. So the first was this evaluation of performance of different HRA triage strategies in men who have sex with men with HIV. And so their goal was to determine the best strategy for HRA triage in MSM with HIV to efficiently allocate resources. So they ended up looking at 180 men who have sex with men with HIV and collected anal cytology, anal HPV, and high-resolution anoscopy all on the same day. As you can see on the demographics table on the left, age was 47 median CD4 nadir was 350, so still quite high, although there was a pretty widespread, as you can see there. Current CD4 very high, 800 median, and a pretty high median CD4-CD8 ratio. Everyone was undetectable. And then on the right, we have the results. So you can see the various cytology results. Almost 70% had LSIL, or low-grade squamous intraepithelial lesions. 75% had a high-risk HPV strain. Of those, 54% were HPV 16, which is significant because that's most associated with progression to anal cancer. And then you can see that in 43% of the HRAs, histologically HSIL was found. And that's important because that's going to be classified now for us in the study as the true positives. And all of these results were kind of made into various hypothetical combination thresholds for referral to HRA to see how those performed. So what you can see here is their kind of look at sensitivity and specificity for each of these referral thresholds and their outcomes. And in the bottom right, it's how many HRAs would have been triggered if we had done the top as our screening method. So the best combination of sensitivity and specificity was high-risk HPV, which I have boxed, with a sensitivity of 87% and a specificity of 63%, with a positive predictive value of 65% and a high negative predictive value of 85%. I also want to highlight, though, that the 2 boxes on the right, the combination of anal cytology, either ASCUS or LSIL, and high-risk HPV does seem feasible. And what you can see is the sensitivity drops, but the specificity goes up. And if we're thinking about how we're going to do screening, this will probably be periodically, right? Not just once. And this is fairly consistent with other data. And then again, the conclusion is that adding on high-risk HPV testing to abnormal cytology might also be another way to think about triaging. This was a poster that was not presented as an oral abstract, but I thought was pretty striking. This looked at CD4 nadir and anal cancer risk in a group in Spain. So it was all treatment-naive people with HIV in this region of Spain, looking at incidence rate of histologically confirmed anal cancers. What you can see is that people with HIV with a nadir CD4 below 200 had the highest risk of anal cancer and quite a bit higher than those with a high CD4 nadir. People with that high CD4 nadir had a similar risk of anal cancer as compared to the general population. And the other things you can see are that age, being MSM, and nadir CD4 count all had the strongest association with anal cancer risk in people with HIV. So again, consistent with data from prior studies, including ANCHOR, but I think important to point out. Finally, this group looked at anal self-sampling for high-risk HPV detection, which I thought was really interesting. So we've talked a little bit about more high-resource settings and resources being limited. This group was really looking at how even cytology would be limited in certain settings, such as sub-Saharan Africa. So this study was carried out in Togo and was an evaluation of anal self-sampling, or ASS. And some of you have heard this joke before, but I did not come up with that acronym. That was the study presenters, for high-risk HPV detection as compared to anal swab by practitioner, or ASP, in 188 men who have sex with men, 67% who had HIV. So the practitioner would conduct the swab by practitioner and the anal exam and cytology. And the overall takeaways is that this was really acceptable. Most people found it really, really easy and, in fact, preferential. So 60% preferred ASS to ASP and nearly 20% didn't have a preference. The same amount of samples basically were uninterpretable, 6 versus 4%. So instead of, in terms of quality of sample. And then there was substantial agreement between the methodologies for high-risk HPV and HPV-16. So nearly 90% concordance in both. At least one high-risk HPV strain was detected in 83% of ASS samples and 77% of ASP samples, and HPV-16 was detected in 28% of self-samples and 26% of practitioner samples. All the discordant HPV-16 samples had a pretty low HPV-16 viral load, explaining that. So I think, again, the big takeaway, high concordance between these sampling methods, whether self or practitioner. It was found to be highly acceptable and easy to self-sample. And so again, as we start thinking about methods to improve anal cancer screening and really achieve our targets, especially in low resource settings, self-sampling might be something that we continue to think about. So takeaways in discussion of how to develop guidance for high-resolution anoscopy referral, we should be considering HPV testing, type 16 specifically, inclusive of self-sampling in certain cases, using anal cytology in combination, and then thinking about certain demographic factors that might help us. And I'll note that we are awaiting anal cancer screening guidelines from the OI guidelines. I think they should be coming out soon. But there are guidelines from IANS, the International Anal Neoplasia Society, that were updated at the end of January of this year, and I think reflect a lot of this discussion. Okay, so we'll switch gears a little bit now to metabolic complications. So I specifically want to talk about GLP-1 receptor agonists, which I think we're all seeing more and more and are very familiar with. But as a reminder, their mechanism, at least as a diabetes medication, is to promote insulin release and suppress hepatic glucose output. Semaglutide, we've heard a lot about, great success in diabetes with pretty big decreases in A1C, significant weight loss, and improved cardiovascular outcomes. And in people without diabetes, still significant weight loss and significant cardiovascular benefit. What hasn't been studied, and as usual, who's a group excluded from the initial studies, are people with HIV. So the first abstract I wanted to talk about was this study called the Slim Liver Study. And this was really looking at metabolic dysfunction-associated steatotic liver disease, which previously you may have heard called NAFLD, now MASLD, is common among people with HIV. Semaglutide is associated with metabolic improvements, including improved hepatic steatosis. And again, steatotic liver disease is quite common in people with HIV and more so than in the general population. So Slim Liver looked at effects of semaglutide on hepatic steatosis, and they did this by looking at MRI proton density fat fraction, or MRI-PDFF, which basically quantifies the amount of intrahepatic fat through something called intrahepatic triglyceride content, or IHTG. So in this study, there were 49 people with HIV who were virally suppressed with elevated minimum waist circumference, insulin resistance, and more than 5% of IHTG on MRI-PDFF. And they were all initiated on semaglutide and then up-titrated over 24 weeks, and then had that MRI-PDFF performed again at week 24. So here are our takeaways. So I have the demographics again on the left. I think the bigger takeaways are the median BMI, it was 35, median CD4 was quite high, and more than 80% were on an integrase-based regimen, which I think is important to point out as we think about who is gaining weight among our population of people with HIV. And then in terms of percent change, there was a 31% reduction in IHTG among all participants. 58% of the participants had a greater than 30% relative reduction in IHTG. 29%, so nearly a third, had complete MASLD resolution, which was an absolute IHTG of less than 5%, which is usually associated with histologic resolution. And what you can see here too is that the IHTG improvements were correlated with weight loss. So those who lost weight had those improvements. Those who did not lose weight did not see these improvements. Weight circumference, fasting plasma glucose, A1C, and serum triglycerides all decreased as well. This wasn't powered for a subgroup analysis, but there were greater IHTG reductions in women, Hispanic and non-Hispanic whites, and participants over the age of 50 years. There are two other abstracts I wanted to highlight, thinking about semaglutide. So the first is still part of Slim Liver, and this was specifically looking at muscle structure and function. And that's because semaglutide causes fat loss, but may also lead to muscle loss. And what the study authors found is that the use of semaglutide was associated with the loss of psoas muscle volume, but there was no change in physical function, which they were measuring by chair rise time and gait speed. And there was no change in muscle fat either among those participants. And then out of UW, the CNIX group, Heidi Crane was the one speaking, we looked at an impact of semaglutide on weight change among people with HIV, stratified by baseline BMI. And the big takeaway is that there was more weight loss at a higher degree of obesity, but it was pretty significant weight loss. So just across the board, 5.7% of body weight. And the other part I wanted to highlight was that in a sensitivity analysis, weight loss was the same regardless of integrase inhibitor use. So takeaways, use of semaglutide in people with HIV is associated with significant weight loss, can be used for successful treatment of steatotic liver disease, may impact muscle volume without impact on physical function in the short term, but we really need longer term data, and what we really absolutely need is access to the medication. I don't know what you all have faced, but it is hard just from a supply chain perspective to get semaglutide and also from an insurance perspective, especially in people without diabetes. All right, so we will end with hepatitis B vaccination in people with HIV. So as you have all heard before, Hep B vaccine seroprotection rates in people with HIV are lower than in adults without HIV, even with the conventional Hep B vaccine, the Hep B alum. So the Beehive study, or ACTG 5379, sought to answer the question, does Heplisav, or Hep B CPG, work better in people with HIV? And there are two arms. Arm B, in those who are vaccine naive, has already been presented and published previously and demonstrated that 100% of people with HIV receiving the 3-dose series of Hep B CPG achieved seroprotective response, and 84% had a Hep B surface antibody titer of greater than 1,000. Almost 99% achieved SPR after just 2 doses, though at lower titers, 28% greater than 1,000. And again, remembering that the threshold for seroprotection is greater than 10. There's this nice slide from the National HIV Curriculum that kind of outlines the study as a reminder to us all. So now we're looking at Arm A, those who were previously vaccine non-responders. And these individuals are divided into 3 groups, those who received 2 doses of Hep B CPG, 3 doses of Hep B CPG, and then 3 doses of the conventional Hep B vaccine, or Endrix. The baseline characteristics of each arm, I can tell you, are pretty even. Median age was in the mid-40s, about a third were female. The nadir CD4 median was above 200, and the median current CD4 median was very high in the 600s. The majority of individuals were virally undetectable. So here you can see the primary figures looking at results. So first on the left, the primary proportion in each arm of Arm A who achieved seroprotective response. So in the 2-dose series, that was 93% of individuals. In the 3-dose, 99% of individuals. And with the conventional vaccine 3-dose series, just 80.6% of individuals. And what you can see is both the 2-dose and 3-dose series of Hep B CPG achieved superiority over the conventional Hep B alum adjuvant. For interest, this is the distribution of anti-Hep B surface antibody titers at those respective endpoints. The darker shade of blue is an increased titer. 96% of participants, you can see in the 3-dose arm, achieved titers of greater than 100, even though we were talking about greater than 1,000 before, and that's 78%. In the 2-dose arm, 70% had titers over 100, with 26% over 1,000. And again, that light blue of 10 to 99 is still a seroprotective response greater than 10, but just as we talk about magnitude, it's quite profound. So takeaways, people with HIV with non-response to conventional Hep B vaccination series achieved superior seroprotective responses as compared to 3 doses of Hep B alum. 3 doses of Hep B CpG achieved high proportion of seroprotective response with a high proportion with surface antibody titers greater than 1,000. This does beg the question, do we need titers this high? I think the answer is for most people, probably not, but there was an underrepresentation of factors that are typically associated with poor response in this study. So very few people had low CD4 counts, very few had HIV viremia, hepatitis C, or older age. So I think that ends up being a shared decision-making with your patients, I think, in those conditions. And there were no unexpected safety issues or deaths. So I know that was a series of disparate topics, but just to take home some of these points, when we think about anal dysplasia, a triaged referral process, including some of the factors we talked about for anal cancer screening, may help tailor the population who will benefit most. Semaglutide leads to significant weight loss and improvement of steatotic liver disease in people with HIV. And Hep B CpG is now superior to conventional Hep B vaccination in people with HIV who are prior vaccine non-responders. All right. Thanks so much.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.